Morning, everyone. Good morning. Let's have a look, see who we got in. We got Danny. Good morning, Danny. Good morning, Martin. And I think happy birthday, Martin, as well. Uh, cool. We've got some of the regulars in. That's good to see. So everything looks as if it's working. So we will get going. It's obviously been a couple of weeks since we last did this. So yeah, all good. Thanks, Stevie. Good to see you're in as well. Yeah, so got back from the States last Monday. So obviously couldn't do the session as usual on Monday. And yeah, back to everything. Becky, good morning, and I'll send you that link today. I promise. It was my birthday weekend over the weekend, so apologies. Yeah, a few things I was supposed to do, I didn't do. No, Becky, thank you for joining us. Right, let's get you guys going. So this is where we finished off. So we were looking at the femoral nerve and its influence on the knee. It doesn't actually the femoral nerve doesn't actually go like toward, it goes towards the knee, but doesn't go anywhere near the patella. It stops just above the patella, and then there's a sensory branch that then goes past the knee and then into the lower leg. Good morning, Tris. Oh, we've got quite a few in this morning. That's good. Thank you, Martin. Thank you very much. Getting closer to 50. So yeah, we start to look at this, and we'll obviously look at the origins of the femoral nerve when we get to the lumbar spine region, and we'll also have a look at the femoral nerve around the hip as well, because of as it passes through those structures. But we're focusing around the knee. So we were looking at these. Just get me arrow there. So we've got a couple of divisions of the nerve which we were looking at before. So we covered this last time, so I'm just going to skim through these. Just get rid of that as well. There we go. Um, closer to 60. Well, you don't look it, mate. So we've got it, when the femoral nerve comes underneath the inguinal ligament, which we haven't covered yet, which is in near the hip. It splits into two, and we've got usually, and we've got an anterior division and a posterior division. Okay, so the anterior division supplies the pectineus muscle and the sartorius muscle. So we've not really looked at pectineus because that's to do with the hip, okay, but sartorius we have because of its influence on the knee. But then sensory wise as well, we've also got a cutaneous nerve, the medial cutaneous nerve, which supplies the kind of around the kind of front to the inside of the thigh. And cutaneous is basically to do with the skin, so it provides sensation to the skin, and it's a bit because we teach what we call dermoneuromodulation courses in the UK, and the symbol that we used for the brand was a tree, and that's basically what it looks like. So you have the kind of roots in the muscle, and then the trunk then pierces through the fascia, and then the leaves then kind of go on the undersurface of the skin and then supply the skin with the sensation for the skin. So if you get touched in the skin, then that information is then relayed via those cutaneous nerves through the trunk into the roots and then back to the nerve root, okay, in the spine. So if you've not heard of that word before, cutaneous nerve, it's basically a medial cutaneous nerve is a midline skin nerve. That's basically what that means. And then we've got intermediate cutaneous nerve in between skin nerve. Okay, so we've got the kind of sensation to the front and the inside of the thigh. There are some overlays with other nerves as well, and then we've got the. Ooh, smooth that. Let me just lock that in place. Hopefully there we go. And then we've got the motor branches here for the posterior division. So you've got rectus femoris, you've got vastus lateralis, vastus medialis. So all of those muscles that we've covered, and then vastus intermedius and articularis genum, which is the one that is just above the suprapatellar pouch that lifts the pouch out of the way as you extend the knee. Okay, so it doesn't get pinched by the patella. And then sensory wise, on this posterior division, we've got something called the saphenous nerve, and that is a really, really long nerve, and that's the one that does go past the knee and goes down into the leg. Okay, so above the knee is the thigh, and then below the knee is the leg. So the shin bone really is the leg. So the saphenous nerve will go all the way down to the foot, and then we've got these articular branches. Articular means joint, and they will supply the joint capsule of the hip and the knee. Okay, so that was a bit of a recap of the femoral nerve. This is it as a schematic. I think this is from the book Instant Anatomy. Somebody asked about this the other day. This is a really good book. It lays things out really, really nicely. So you can see here, so you've got L2, 12, 4, so those are your nerve roots. And then as it, obviously in an inferior direction, so it's coming down here. So it's femoral nerve here, and then we've got a motor branch that comes off in the abdomen to the iliacus muscle, which again we haven't covered because it's to do with the hip. Then you've got the nerve to the pectineus. And then if you have a look here, so around this area here, this is where it splits. So you've got the lateral circumflex artery. So it splits around that artery area. And we're going to have a look at that circumflex artery when we get to the hip again. Okay, so it will all start to kind of piece together. And then this is the bit we've been looking at. So this kind of section here. So we've got a branch off to the hip joint, rectus femoris, vastus lateralis, intermedius, one for the knee joint, so an articular branch just here. So you can see how it kind of splits off. And I think I described this before as like a kind of like a horse's tail. So if you've got all the little strands of hair, or like a ponytail, all wrapped up, and then coming from here, L2-12-4. We don't know around this area here which is which, whether it's a motor nerve, so sending information to the muscle, or a sensory nerve bringing information back in. So at this point here, it's mixed. Okay, so it's a mixture of the two nerves, and they're all bundled together. And then here, this nerve to pectineus, this is purely motor. Okay, so what will happen is a strand of hair will come off, and then it will attach itself to the pectineus muscle, and then when the information from your brain is sent down to do whatever movement, well, adduction or stabilization of the hip, pectineus will then contract, or it will set off the motions for contraction, and that is all that will happen along that nerve. Okay, obviously other muscles and other nerves will kick in as well, but that's what will happen with that particular one. And then as we come down here, so you can see here we've got the medial cutaneous nerve of the thigh. So that's sensory. So that's sending information back. And then we've got this one here going to sartorius. So that's sending information down. So even here, that level there, that's still mixed. Okay, so you've got a mixture of the two. And then once you get past the knee joint, this saphenous is purely sensory. So it's only sensation, and it goes on the medial side of the leg, so the inside of your calf, and then onto the medial side of the foot and up to the ball of the great toe. So all the way down the inside of your leg, basically. Okay, so calf, down the inside of the foot, and then towards the big toe. And that's purely sensory. So that is just supplying the skin. So any sensation to the skin will be coming back up via the saphenous nerve if it's being picked up on the medial aspect of the leg. Okay, hopefully all that makes sense. Right, so this should be a recap. So we've got L2-L4 femoral nerve. It's in the anterior compartment, so that front compartment of the thigh. And you can see here, these are the nerve roots. This is as it comes underneath. There's the inguinal ligament. We've not really talked about that much. Talked a little bit about the femoral triangle. As it passes underneath the ligament, it then splits. So you've got anterior, posterior division, and then it will split off into the various muscles or skin sensation. And then if you have a look here, as it travels down here, there's your saphenous all the way down to the big toe. Okay, so that's what it looks like. Let's have a quick look at the videos again. I think this one. Yep, that's the right one. That's good. Okay, so yeah, so that's the image that we were just looking at. There's your lumbar vertebra. There is, let me just pause that there. So there's your obturator nerve, which we haven't covered yet, but there's the inguinal ligament just there. Okay, so that bit there. So that there is your ASIS, okay, anterior superior iliac spine, and then that bit there is your pubic bone. So what's happened here is they've removed half of the pelvis. Okay, so you can see on the inside of it. So there you go. So you've got femoral nerve, obturator nerve, and then psoas muscle. That's why you don't really want to be jabbing around someone's psoas, because it's quite close to the femoral nerve, and it will make their leg go funny at the front. So there's your obturator, there's your femoral, and then here it comes, iliacus muscle just there. There's your inguinal ligament, and then this is the branches. So these, just pause that there. So this is what it looks like, yeah. So you get the main ponytail of all the strands of nerves go either receiving or giving information, and then can you see here that they literally just kind of rest into the muscle, yeah. So they're obviously quite a firm attachment there. But then this is where all of your sliding filament theory stuff comes in. So you receive a nerve impulse. It's the all or none law. So it either is enough of an impulse to make the muscle contract, or it's not. And if it is, then you'll change from a nervous system, nerve impulse, electrical stimulation, into then a chemical reaction. So that nerve impulse will stimulate the release of calcium, which then floods the sarcomeres of the muscle, which then kickstarts the actin and myosin binding together and then creating a contraction. Okay, so it goes from electrical information, chemical information, contraction. Okay, and again that's happening all the time, and that's quite important to know when we're looking at certain disease processes, because there are some conditions where you will have a problem with some of the either the nerve impulse or a chemical reaction, and they look slightly different. And so when that nerve impulse is received around the muscle, it gets to the end of the nerve, so the end bulb, I think it's called, and then you've got neurotransmitters stored in that end bulb, and then they then pass across what we call a cleft. So there's like a gap in between that don't actually attach. There's like a that they do in real life via fascia, but there's it's the neurotransmitter that crosses the cleft, and then that stimulates then the release of calcium. So it's there can be a problem with that neurotransmitter. There can be a problem with the nerve impulse coming into the muscle, or there can be a problem with the muscle itself. Okay, so if there's an injury to the actual tissue, so there's various different things that will happen at different stages, and depending on what the problem is, it will give you different kind of symptoms. Okay, so it's all that happening like in that tiny little spot there. So that is sartorius just there, this big chunky muscle here. So there we go. So we've got iliacus supplied by the femoral nerve, all of your quads, so vastus lateralis, medialis, so on and so on. Pectineus, inner thigh, sartorius, so this one here. And then there's your sensory distribution. Okay, so you've got all the cutaneous nerves. So let's have a look. So like intermediate cutaneous nerve, let's just go back. Pause that there when we get to it again. Here we go. Okay, so these ones here, so intermediate cutaneous and medial cutaneous nerve of the thigh, that's this red zone here. Okay, so those two nerves, those two cutaneous nerves, will supply the skin over the front of your quads. Okay, this one here, the blue one, that's this bit. Okay, so that's the saphenous nerve coming down there. Yeah, and then supplying the down towards the big toe. So that's your sensory distribution for the femoral nerve. Okay, cool. There's your recap for that. Right, let's move on to, I think there's another picture there. Yeah. So then we're going to have a look at the obturator nerve. And again, it does kind of influence the knee, but not directly. Okay, so it kind of like skirts around that kind of area. It's mainly inner thigh, this one. So we've got L2 to L4, so it's exactly the same as the femoral nerve around that area there. And there is a hole in the pelvis here, just there, where your sit bones are. And that's called the obturator foramen, which basically means obturator hole. Okay, and the obturator nerve goes through that hole, and it's on the inside of the pelvis. So if you think about the pathway of this nerve, it's going to be supplying your inner thigh. So whereas the femoral, if we just go back there, so there is a crossover here. So can you see that patch up there? So right up towards your hip, on the inner thigh on your hip, that's predominantly where your obturator nerve sensation-wise will provide. There will be some crossover as well with the femoral nerve, but predominantly it's like right up high on the inner thigh, and that's why is because of where it goes. Okay. So sometimes it will pass through the external obturator muscle, and again we've got a split of the obturator nerves. So we've got a posterior and an anterior branch. Okay, so these are the branches then. So very similar to the femoral nerve where we've got a anterior and posterior. So we've got 4 motor, 1 sensory branch, 1 articular. So motor to the muscles, 4 muscles, 1 patch of skin, and then 1 joint capsule. Okay, so motor branches: pectineus, adductor brevis, adductor longus, and gracilis. So although the nerve doesn't travel down towards the knee, it will have an influence on the knee because of gracilis. Okay, because gracilis, the muscle, attaches into the pes anserion on the tibia. Okay, and again, if you're just joining us now and you haven't done any of the other stuff to do with the knee, go back and watch those, because some of these words will be like, what the heck are you talking about? So go and have a look at where gracilis attaches and watch it through the series, okay? Because otherwise this will be quite confusing. And then sensory wise, we've got the obturator cutaneous nerve. Okay, so if we have a look here, there's the cutaneous branch just there. Okay, so that one there. So it's remember that patch that was white on the femoral nerve picture? That's the nerve that fills in the gap. Okay, so it's that one just there. And then we've got a articular branch which will come up. See here. So we've got an articular branch up to the hip capsule from the obturator nerve. It doesn't say it on here for some reason, but yeah. So you can see that little branch coming off there. So that's going into the hip joint capsule. Okay, and then we've got the posterior branches. We've got 2 muscles and 1 joint. And if you have a look at this one, this is going really, really long now, all the way down here, and then coming towards the knee. Okay, so motor branches, obturator externus, which again we haven't looked at yet because that's to do with the hip, and then adductor magnus that we definitely have had a look at. A really, really big, powerful muscle that doesn't cross the knee, mainly does work on the hip. So you've got adduction, hence the name adductor, and also hip extension. Okay, so those are the 2 main actions of adductor magnus. But then there's this articular branch, so a joint branch that goes towards the knee and into the knee capsule. Okay, so any kind of sensation in the knee capsule will be picked up by the obturator nerve. Okay. I missed the context of that. Sorry, Stevie. Kind of like a motherboard. I'm yeah. I'm guessing you mean kind of like towards the nerve root stuff. Um, and again, Tris, I'm not sure the context of this one as well. Um, yeah, don't know. I'll try and guess sometimes. It is funny because I say stuff and then miss the messages, and then I'm like, I have no idea where what that's related to. Apologies. So here is the schematic. See again. I love these. I think they're so it make it so clear. So we've got L2 to L4 through the obturator canal or the obturator foramen. Again, this is an annoying thing with anatomy that they call the same thing different blooming names. So you go, well, where the heck is the obturator canal? And it's basically the obturator foramen, which we just looked at. And then we've got the split. So you got anterior, posterior divisions, obturator muscle, and then down around adductor brevis towards adductor magnus, through the adductor hiatus, which we'll have a look at in a second, and then our articular twig to the knee joint. Love that. Rather than a branch, it's a twig. Okay, so that's going towards your knee capsule. Okay, and then on this anterior division, we've got an articular twig again to the hip joint. So again, I'm supplying that hip capsule. So if there's any odd sensation in the hip capsule, then depending on there's several branches that supply this area anyway, but you will get information via the obturator nerve. Pectineus muscle, inner thigh, again adductor brevis. So the posterior division passes around adductor brevis, whereas this one supplies it. Adductor longus gracilis, which is part of your adductors again, and then the cutaneous branch to supply the skin on the medial aspect of the thigh. Okay, so inner thigh region there. Okay, cool. All right, there you go. So that's the obturator nerve skin sensation area. So if someone's complaining of lack of sensation on the inner thigh and you test it and it's reduced for whatever reason, then again, if you think about where everything connects to, so could it be that there's something wrong with the skin? Okay, so there's been maybe an injury to the skin. Give you a good example of that is if you have burnt yourself or cut yourself quite badly and damaged the nerves, but then everything's healed up, you may never get sensation back again, but it actually looks normal. So I did that with my thumb. I can't really feel certain areas of my thumb because it's just become normalized, which is in fact just touching it now makes it feel a bit weird because I haven't thought about it for a while. But the sensation is altered, and that happened like 10 years ago. But the skin is all healed and it doesn't look damaged. But if I did a neurological test over my thumb, and I go, oh, yeah, I can't feel that very well. You can't just assume that there's a problem with the nerve that is new. There may have been something that had happened before. So it's always worth questioning, well, have you injured that area before? So that's the first thing. Then is the information that is on the skin being relayed to the nerve and then along the pathway back to the nerve root. So is it a problem along the cutaneous nerve? So maybe some kind of compression. Okay. That is classic with something called the lateral cutaneous nerve. So we'll have a look at that when we get to the hip. There's a condition called paresthetica meralgia, or the other way around, meralgia paresthetica, where you lose sensation to the outer part of the thigh, just here, and that's because of a compression up here, usually of someone wearing like a belt or something like that that's a bit too tight. And because it's so tight, it compresses the nerve here, and then you lose sensation to the skin all over the outside of the thigh. Okay, quite a common one with police officers, people who wear utility belts, that kind of thing. But there's nothing wrong with the nerve along the skin. It's here. Okay, so if you think about the pathway of this one, maybe there's nothing wrong with that patch of skin. It's just being compressed in a part where the cutaneous nerve, of the pathway of that nerve? Okay, or is it a problem with the nerve root? Okay, so L2 to L4, there's an issue there, maybe a disc bulge or something like that, whatever it is. Okay, so it's not as simple as just saying, oh, you've got loss of sensation there, it must be that. There could be several things, so we need to get them investigated. Cool, right, let's have a look at this. Here's obturator. Just pause that there a second. So, articular branch of the anterior of the obturator. Right, let's just go back to that quickly. So, there we go. Is that going to move? Yeah, good. So, here is the anterior division. There's the articular branch to the hip joint. Okay, so the anterior division of the obturator nerve has a branch that comes off and supplies the hip. Okay, so that's what that one is. And then, could this complaint also be someone who is rather overweight? Yes. Yeah, so that's quite common as well, with that lateral cutaneous nerve compression. But especially if they're at a desk all day, that kind of thing, or a lot of sitting down. Yeah, that's very common as well. Yeah, good. Cool. Right, let's have a look. So, obturator nerve. I got those in time this time. Okay, so here we are. So we saw this view before and we were focusing on the femoral nerve, which was this one just here. Now we're going to have a look at the obturator, which is here. So can you see the pathway of it there? So there's the inguinal ligament. There's your pubic bone just there. And then that there is the is what one of the branches of the pubis, so the rami of the pubis. And you can't see it, but just underneath there, that's where the obturator foramen is. And then you've got your sit bones just down here. So we'll have a look at it in a second as we pass through, but just to give you a bit of a orientation. So inguinal ligament, there's your pubic bone. There is the obturator. Look at it, there it goes. So it's going on the inside near the pubic bone. There's your obturator muscles. And then you can't see it at the moment because pectineus is in the way. But there we go. So we take pectineus away, and pectineus is one of your hip adductors. And so again, we'll cover that when we get to the hip. But there's the hole. Okay, there's the obturator foramen, or the obturator canal, as it's said here. So that's that bit just there. Okay, on the schematic. And then you can see it branches off into an anterior and posterior division. And there it is. Okay, obturator externus just there. But that's what I mean by look at how it attaches into the muscles. Yeah, so physically it will attach, like anatomically, through fascia. But the theory is, with like say with sliding filament theory, is you get to that end bulb and it's full of neurotransmitter, and then that's what passes across the cleft, the gap, and then goes into the muscle to cause it to contract. Okay, so obviously that will be microscopic. You can't see that with the naked eye, but that is what it looks like when a nerve attaches into a muscle. Yeah, always amazing me how fine the nerves are given the power that they have. Yeah, but it's weird though, because they're again, I've used this analogy before, and they're a bit like they're kind of tough, like calamaris. So they have that kind of consistency, or texture, whatever the word is. So here's all the muscles that are supplied. There we go. So anterior portion of adductor magnus, and then there's your. I'll just move that out of the way. So there's your sensation. Okay, so inner thigh, just there. So that is your obturator nerve. So obturator, I think obturator means to close. Yeah. So if you obviously to closing your legs is adduction, and that's what obturator means. Cool. Right. Let's have a look. Last one, sciatic nerve. What time is it? Yeah, I want to get this and the blood supply done today, so I can get on to. I'm going to do a session on lymphatics. I've been asked to do that, so let's go. So sciatic nerve L4 to S3. So a little bit lower than your obturator and your femoral in terms of nerve root. Okay. So we're going into the kind of lumbar sacral plexus. Okay, that kind of area. And again, we'll do a whole session on that. This is an interesting one because if you've got odd sensation on the back of the thigh, like you lose sensation around the hamstring area, there are no cutaneous nerves, okay, from the sciatic nerve, because we would imagine that it was sciatic nerve, yeah, but the sciatic nerve here in the back of the thigh doesn't give off any cutaneous branches at all. They're all motor, okay. So sciatic nerve is divided into tibial and peroneal, and the sciatic nerve isn't really a nerve, it's two nerves, okay, and they're bundled together. And I've mentioned this before, sometimes they split really high, so you've got kind of two sciatic nerves, but it's basically the tibial nerve and the peroneal nerve have split a lot higher than what is shown in a lot of the textbooks. So and it's usually around this piriformis area. We see a lot in the labs where they split around here. Okay, so kind of ischial tuberosity area. In the textbooks, it's just above the knee. Okay, but that's often not the case. So we've got four motor branches, and if you think about the other ones, they had cutaneous branches and articular branches as well. This one in this region only has motor branches. So we've got biceps femoris, semitendinosus, semimembranosus, and adductor magnus. Okay, so if you remember before, adductor magnus also had a feed from obturator. Yeah, so obturator does the adduction part, and the sciatic nerve does the extension part of adductor magnus. So if you injure your hamstrings and you completely avulse your hamstrings from the ischial tuberosity, you will still be able to extend your thigh because of the adductor magnus branch. Okay, which is quite handy. And then sensory, none in the thigh. It provides sensation to the leg, so below the knee, when it divides, which is what we covered previously. Okay, just before Christmas. So that's for me, that was quite interesting because you always think if you lose sensation at the back of the thigh, or someone complains of pins and needles at the back of the thigh, you think, oh, it must be sciatica or sciatic nerve, but you don't have any skin sensation there. Okay, the skin sensation comes from here. Just going to move that. So yeah, what about the skin sensation to the back of the thigh? So we have got S1 to S3, three branches. We've got a cutaneous branch, which is the posterior thigh. And if we have a look here, so posterior cutaneous nerve of the thigh comes from S1, S3, not from the sciatic nerve. It's not a branch off the sciatic nerve. It's the same nerve roots, okay, but there's another branch that comes out of those nerve roots that is just sensory. So it's not like your sciatic nerve here, and then there's a little distribution off of that. This is a different nerve, okay, a different nerve completely. And there's the sensation it supplies, okay. So there's the skin area that it supplies. So it's all the back of the thigh. So if there's a problem here in terms of skin sensation, then it's coming from S1, S3. Okay, and then you've got the cutaneous branch. We've got gluteal part, so the lower part of the buttock, so that kind of underneath your butt cheek, and then the peroneal branch, which is your either scrotum or labia, obviously depending on your sex. Pelvic pain can masquerade as sciatica due to the shared parasympathetic pathways at S2, S3. Okay, so you get this sensation down the back of the thigh, and you think sciatica, but actually it if it's a skin sensation issue, then it can't be coming from the sciatic nerve. So yeah, I don't know whether that's new information, but it's quite useful, I think. So if we have a look here, this is the lateral aspect of the thigh. Yeah, so this was the lateral cutaneous nerve. There's the inguinal ligament there, and the lateral cutaneous supplies this area here, so the outside of the skin. So the femoral front of the thigh, and then all on the outside here, that is supplied by L2, L3, mainly L3, lateral cutaneous nerve. There you go, meralgia paresthetica. So it's the carpal tunnel of the thigh. And as Becky mentioned, if someone is overweight, it can compress that inguinal ligament, or a tight belt, utility belt, that kind of thing, that can also compress it. So that kind of wraps up all of the sensation now all the way around the thigh. So at the front, femoral nerve, on the inside of the thigh, obturator, round the back, posterior cutaneous nerve of the thigh, not the sciatic nerve, and then on the outside, lateral cutaneous. So all of those are the sensory nerves that supply the skin for the thigh. Okay. Nearly there. The nerves is always nerves is always a tough one. Okay, let's have a look at this. So this is sciatic nerve. Just looking at the time there, I think, oh, am I going to be able to get these blood vessels in? Maybe. Okay, so we've got femoral nerve at the top. Let me just get that there. So there's the femoral, there's the obturator, and then there's the sciatic. Look at the difference in size. Yeah, sciatic nerve is huge. Let me just move that there. So all of these nerve roots come in together to form two nerves. Little branches coming off. We'll talk about these foramens and stuff. Not really bothered about those right now. We'll do that when we get to the hip and the pelvis. So there's your femoral coming down there. So now we're looking at the back. So you've got your glute max. And then there's your piriformis muscle. And then there is your sciatic nerve, or the tibial and the peroneal nerve. Shouldn't say peroneal, fibular nerve. Some little kind of areas that it crosses over. Quadratus femoris we've not talked about because that's to do with the hip, but here we go. This is the bit we have. So the sciatic nerve passes through your two heads of biceps. Okay, so biceps femoris, and it supplies semimembranosus, semitendinosus, biceps femoris, which is the lateral head, and then the posterior aspect of adductor magnus, and this is it at the knee. Okay, so this is really cool. Here we go. So there's your biceps femoris. If I just pause that there. So these are the things that we were looking at previously. So there's the calf. Okay, so you can see the two heads of gastroc. You've got the nerve coming down and the blood vessel as well with it. So this area at the back here, which forms like a triangle, this is the popliteal space. Okay, and so the space at the back of the knee. So that diamond there, popliteal fossa. There's your hamstring. So there's your sciatic nerve there. Biceps femoris, it comes through those two heads, so passes through them, and then there it is there. So there's the blood supply, and then there's the nerves, and you can see the branches which we looked at when we were looking at the leg. So tibial nerve and the fibular nerve coming down there. Gastrocnemius just there, so you can see the two heads of gastroc, and again you can see these little branches coming off and feeding into the muscles. Common peroneal, or the fibular nerve, as we are trying to call it now. Okay, so all of these we looked at when we looked at the leg, and we followed the pathway of those down into the foot. So again, sciatic nerve, splitting, tibial nerve. So tibial nerve supplies your popliteus, gastrocnemius muscle, plantaris. Cool. And that is that one. Good. Right. Let's see how we get on with this. Hope everyone's all right. This is a bit of it is one of those ones where you're like, oh my god. Right, I'm going to I'll probably do an introduction to the blood supply, and then we'll finish it off next week. Okay. I don't think we're going to be able to do it all in one go. So blood supply, we've got different arteries that are called different things at different points of where they are in the body. Okay, so sometimes they're the same vessel, but depending on where they are, will depend on the name that they're given. Okay, so we've got femoral artery, which is obviously around the femur. Profunda femoral artery. Profunda means deep, so like profound. And then genicular, anything with genum, genicular, genu, all of those is to do with the knee. Okay, so we've got a specific artery or branches that supply the knee. So artery means a windpipe, and it's because when you die, obviously your heart stops pumping, so the arteries are empty. Okay, and they thought that when they first started looking at cadavers, that they look like air tubes. Okay, so that must be a way that we breathe. Okay, obviously we know different now, but they the veins are full, but the arteries are empty. When you die, because of the lack of pump. Okay, so that's where artery comes from. This is the cool bit. Okay, so we've got stuff that we've had a look at before. So there's the ASIS where the sartorius attaches, inguinal ligament coming across here onto the pubic bone, and then underneath that inguinal ligament, we've already had a look at this. So this was the femoral nerve, and then you got your anterior and posterior divisions. And do you remember we were talking about the circumflex artery that supplies the hip? So there it is there. Okay, so that's going off towards the hip joint, and that is usually where the division of the femoral nerve happens. Okay, around that area there. So this is the femoral artery, just above the inguinal ligament. It will be called the internal iliac artery. The internal, no, external iliac artery. Sorry. So it's one of the iliac arteries, obviously on the either side. So when it's in the pelvis, it's iliac. After it's passed underneath the inguinal ligament, it then becomes femoral. Okay, so it's exactly the same vessel, just given a different name. And then obviously we've got the vein here bringing the blood back from the leg. Okay, so this area here is if you put your finger on your ASIS and then a finger on your pubic bone, and then pretty much go halfway in between the two and then push into that region, you'll be able to feel a pulse. Okay, and that pulse is the femoral artery. That's the one you can feel. That is the only blood supply for your whole leg. Okay, so it supplies everything in the leg. There's no other branches of any other artery. Yet they all come from that tube, and then they split off and do their thing and go to various different places as they go down the leg. But if you need to stop the blood flow to the leg for whatever reason, so say there's some kind of really bad injury, if you put pressure into here, you will stop it for the whole leg. Okay, so it's one of those ones that we use in first aid if there's a catastrophic bleed. Okay, so we'll put some pressure here, and then it will cut off the blood supply for the whole leg. So this is these are the different kind of branches of that femoral femoral artery. So it's coming from here. Just move me out the way. So as it passes under the inguinal ligament, it becomes the femoral artery. And there's your femoral artery there. And then we've got another branch here that is deep. There's your profunda. Okay, so deep means profound is deep. So we've got a branch that goes deep. And then this one here, we've got lateral circumflex, which we've had a look at before. And circumflex just means it kind of goes around. Yeah, so it kind of goes around the hip joint. And that will supply the femoral head. Okay. Yeah, the descending branch of the lateral circumflex supplies the patellar network. So there's a branch also from that comes down and then comes all the way down here and then supplies around the femoral condyles. There's also another little branch, so femoral artery down here. This is the main femoral artery now, all the way down, and then just before it goes to the back of the leg, and we'll talk about that in a second. There's a little branch here, which is the genicular branch, and that wraps around and supplies the femoral condyles near around the all around the patella kind of area. Okay, so all around that knee joint, knee capsule. So those are your genicular arteries because they're to do with the knee. Okay, cool. And here we go. So if I just move me out the way. So there's your descending branch of the lateral femoral circumflex. Okay, so it's coming down here. So that was the one that first of all wrapped around the hip capsule. So there's a branch that comes all the way down. It meets up with your genicular branch and provides this kind of network of blood vessels all around the knee joint. Okay, so you've got a supply from one side, you've got a supply from the other, and then they meet up together and they create this network of blood vessels all around the capsule and all around the patella. And the good thing with that is if you have a blockage to one, you will still get a blood supply from the other feed. Okay, so that's really quite handy, just in case you get injured. And that network of blood vessels is called anastomosis. Okay, and again, you might not have heard of that before, but it's a union of parts or branches. So if we go back to that image there, these are anastomoses. Okay, so that's what they're called. So where they all join together, they're anastomoses. Right, so again, if you've not heard that before, then that's what it means. If you have, then apologies. So there's your femoral artery. There's your genicular, descending genicular artery there. And then as it feeds into the genicular arteries around the knee, this one here, this will be your descending part of the lateral circumflex. That will then join up all around here, okay, and anastomose with the others so that it forms that network. Okay, so that's all the blood supply around the knee. Cool. Last picture. That's now at the back of the knee. So that artery there has changed from the femoral artery into now what we call the popliteal artery. It's exactly the same vessel, but now we've got these branches that are supplying the back of the knee as well. So you've got all of that network at the front, supplying all around the patella and all around the joint capsule, and then as it passes through to the back, it then supplies the back of the knee as well. Okay, so it's pretty fascinating. Let's have a look. So with something like Osgood's, does that mean the blood supply vessels can be stretched? It wouldn't really. It's not the vessels that it affects really. With that, you probably would get an element of it. Let's just go back here. But not really, no. But the problem is with the patella ligament rather than with the blood supply. There will be an element of shifting with things. It depends whether it's completely avulsed or just come away a little bit. Yeah, if it's kind of pinged back, completely come off, then you will have shifted some vessels. But that's not usually what happens. It's usually just a slight shift of where the ligament attaches into the tibial tuberosity. Yeah, that's a good question. Get me thinking. Cool. Let's do that video, and then we're done. Right. Blood supply. Let's do those. Here we go. I know we're running over a little bit, but I think if we can squeeze these in, then that would be good. Kind of tie off this. So this is the proximal blood supply to the knee. All the stuff that we've just been looking at. So that's the bit near the hip and the femoral triangle area. So here we go. So we've got the adductor canal. So vastus medialis, adductor magnus. We have a look at all these muscles previously. So these all form, see, it's like a valley. Yeah, so this is the adductor canal, and this is where the blood vessels will rest on, and then it will come through here, that area there, and that's where it switches to the back of the knee. So there's your femoral triangle. So it's covered by sartorius. And then you've got this little hiatus here. So that's in adductor magnus, which we looked at a couple of weeks ago. And that's quite important, that one, because the blood vessel will come through there and then through the back. And we've talked about that before. So here we go. Here's one of the big veins. So the saphenous vein, all the way down to the ankle. So if you remember, the saphenous nerve follows exactly the same pathway as the nerve. And then that comes back up into the groin. So that's one of your main veins back up. Pubic bone, here we go. Okay, so there's your profundus. Femoral triangle just here. There's the femoral artery coming down. All down there. And then it disappears here. Yeah, around that area there. And that's where it goes to the back of the thigh. So there it goes there. Okay, so it dives deep into that adductor canal or adductor hiatus. And then it passes to the back of the knee. And here it is here. So there it is emerging from the back. Okay, so there's your now it's popliteal. Okay, sciatic nerve is just there, so we saw that just briefly before. So these are your vessels here. So there's your popliteal artery. They're all really close together. Look, popliteal artery, vein, and the sciatic nerve all close together. And there it is on its own. Okay, so that's come through from the front through to the back. And can you see these little branches? Yeah, so those are all the little genicular branches that we were talking about before. Yeah, so they're supplying the knee joint and the knee capsule. Got supplied to the gastroc. Sural artery will supply a little bit lower down, but there we go. Look, these are all the kind of little branches off, and then they all join together. They anastomose all together. Cool. And then one more. Just show you this one, and then we are done. It's been a pretty heavy session today. Okay, so this is just around the knee. Okay, so starting at the inferior part, here we go. So if it, yeah, I think it's the same, it might be the same video, but just focusing around the knee. So all the bits that we saw before, yeah, I think it might be the same video actually. So here we go. So you got that adductor canal. It doesn't harm seeing it again. So that forms the floor of where the blood vessels will go. Blood vessels will pass through. So these are your quads. Okay, so that will pass through where the quads are. Sartorius covering all this area here. Yeah, it is. Yeah, sorry guys, I've got the same video again. And then there's the hiatus. So that's how it passes through to the back of the knee to then become, so as soon as it comes through there, that's then popliteal artery just there. Yeah, it is. Sorry. Vein coming back up. So there's your saphenous vein. That's the one usually, if you get varicosities, that's the one where you get your varicose veins. Pubic bone, femoral artery, there's the profunda, there's the normal femoral artery, femoral triangle just there, and then there it is if we track it down, all the way down, through the hiatus. There it goes, and then there it is there. And then, so now it's passing through to the back. Just spin that around. There we are. So there's the sciatic nerve. These are the blood vessels. So it's coming through the hiatus just here. And now it's the popliteal artery and vein at the back of the knee. Just there. Cool.